My name is Kay Matthews. I am the Executive Director of the Shades of Blue Project. Not only am I the Executive Director, I'm also a patient uh, advocate and a provider. It is I am extremely excited to be here to host today's event. I am sure that we are all going to learn something new today. And so sit back, enjoy, and let's get started. And so today, the theme for our session is building community capacity to address racial disparities in maternal mortality and morbidity. And so I'm going to give a little bit of background on all three of our guests today. I'm going to start with Dr. Twylla. Dillion is the Executive Director of Health Connect One, the national leader in advancing equitable, community-based, peer-to-peer support for pregnancy, birth, breastfeeding, and early parenting. She has over 10 years of experience in the nonprofit sector, including philanthropy, Medicaid reform, maternal child health, data analytics, and academia. Dr. Scott Hartman is uniquely a family physician who delivers babies and thus holds the honor of caring for patients from cradle to grave and throughout the years in between. His experiences in building group prenatal care and inter and preconception health programs in diverse settings has not only enhanced him in the understanding of communities, but have trained him well in implementation science. And then we have Danielle Jones, who is a mental health counselor, doula, and podcaster from Rochester, New York. She has served in the field of human service and mental health for over 10 years. Danielle is also the founder, host, and producer of Mommy Me Time Out podcast. Her mission is to use this platform to educate, elevate, and empower moms to live up to their full potential in motherhood and womanhood at the same time. We would like to welcome all three of our guests today, and I'll get started.
So we have a quick poll for you just to learn who's in the room. Please take a moment to complete this poll, and we will get a good sense of what our community today looks like. Thank you for completing this poll. It appears that we have a quite diverse set of participants in the room today, and we're so happy that you're here to join us. We'll now turn it over to our very talented team of invited speakers.
Thanks, Karen. Good afternoon, everyone. I'm Twylla Dillion, and we are so glad that you could join us today to learn more about our work building community capacity to address racial disparity in maternal mortality and morbidity. Today, Dr. Hartman will cover the epidemiological background on maternal mortality and morbidity in the nation, New York State, and Rochester, New York, followed by Danielle Jones, who will cover the community-focused approach that was used in this work. And finally, I'll wrap up with our results and next steps. We will leave some time at the end for any questions that you may have. First, Dr. Hartman.
Thank you, Twylla, and thank you for those introductions. And we really are honored to be here sharing our work with you today from little old Rochester, New York. So if you want to go ahead and advance it. So many of you are familiar with some of this content, but it's important for us to contextualize things. So we know probably that maternal mortality is defined as early or late within 40 days of delivery or late within 1 year of a delivery. And then we talk about this mortality in terms of pregnancy or non-pregnancy related, so a complication of pregnancy itself versus exacerbation or deterioration of an existing condition. And then maternal mortality is often reported in a ratio of deaths per 100,000 live births within a state, region, country. In the US, our target would certainly to be 0, and 700 maternal deaths per year in the US is a low absolute number, but the fact that it should be 0 is what we're really focused on. So if we could advance to the next slide. And then the disturbing thing too is that we know that in the 1800s and early 1900s, our rates were much higher, And they've actually been decreasing up until the 1980s or 1990s. And then sometime around 2000 or slightly before, we started to see this bump in maternal mortality that has continued to increase over time. So again, small absolute numbers, but the fact that it's increasing is the disturbing part. And also the fact that when we really look at the birth statistics or hospital records, probably 50% of these were preventable. And then next slide. And so we have some, it's hard to measure this and it depends on which definitions we use, but it's pretty clear when you look at the data from different angles that there is some disturbing data here. And so the orange line in this graph is New York City. The green is New York State, and then we've got the rest of the state in the United States, which kind of match each other. But what we can see is that in New York City, the numbers for maternal mortality have actually improved a bit since a spike in the early 2000s. Whereas in the rest of the country and even the rest of New York State, we've seen this disturbing increase that may have leveled off, but obviously we seem to be doing worse than New York City in some ways. And next slide. And then again, what's more disturbing is that there is really this huge racial disparity. And for Black women in New York State, the numbers look the highest, especially compared to white women in New York State or in the United States in general. And that in New York State, we actually looked worse for Black women than in the rest of the United States. So the causes of maternal death, and this is New York State data, it has shifted a bit. So in 2006 to 2008, we were really looking at hemorrhage as the top cause, and then hypertension and some other non-cardiovascular causes. But it shifted a bit now where hemorrhage is still very significant. The venous thromboembolism and infection seem to have become more significant, statistically more significant drivers. And something that some of our New York State people have really focused on is severe maternal morbidity. And this is because the numbers are so low for mortality that we're really trying to look at sort of what's leading to that mortality, but also severe maternal morbidity in other ways may be a better surrogate and something that we should look at when we try to look at preventable causes. So we've been focused a lot more on this recently. Severe maternal morbidity is defined by the CDC as 18 specific conditions, which I won't go into in any detail, but just to say that, they range from cardiovascular and thromboembolic kinds of causes to more infectious or hemorrhage, or hemorrhage related to transfusion. So, and what is also significant about this is it is 50 to 100 times more common than maternal death, and the incidence is estimated to be about 1.5% of all pregnancies in New York State. So severe maternal morbidity in the US has been increasing, and we have some reasonable data. It's almost, I won't say easier, but in some ways it is probably easier to assess this than to assess the cause of death. And so from 1993 to 2014, these numbers have been increasing, but they've been increasing more in Black women than in white women. The major driver seems to be increasing rates of postpartum hemorrhage due to uterine atony, but there are some potential other causes as well. Next slide. And then what we see here, when we specifically look at our New York State data, we found that the incidence for Black women is really almost twice that of white women for severe morbidity. This in some ways parallels the mortality data, but also significant that white, Hispanic, or non-Hispanic women don't seem to have, they seem to be pretty similar in incidence as opposed to Black women. And so what we can conclude from what we have from New York State data so far is that hemorrhage with transfusion really seems to be the top driver. And this is definitely true worldwide, but Black women in general seem to have a higher rate of severe maternal morbidity. And that when we control for things like smoking, living in certain zip codes, and other kinds of social factors, it still doesn't explain those differences. Next slide. And then, so we talk about social determinants of health a lot as underlying these medical causes, and that really we won't get to the bottom of this if we don't look at the social determinants of health. What's interesting is when you look at the New York State data, especially, that when we look at things like gaps in health coverage, lack of coordinated care, inadequate social services, lack of transportation or housing, that there still is a racial disparity when you try to control for all of these things. And so what we really come down to is that structural or systemic racism really has to be at the core of this, and we really have to address that or we won't get to the bottom of this. And so we're presenting our project in Rochester, which really focuses on addressing some of those issues in what we think is a novel way. So with that point, I would like to turn it over to my esteemed colleague, Danielle Jones.
Hi. Good afternoon, everyone, and thank you for the introduction earlier. I'm so excited to be here. So I'll be talking about the community piece of the research. Healthy Baby Network, formerly known as the Perinatal Network of Monroe County, secured the PCORI grant to support this important work. And the organization began in 1996, and they are dedicated to ensuring that every parent in our community has the information and support that they need to bring a healthy baby into a nurturing home. And they offer many different programs to support the community. So some of these programs include health and perinatal education, doula support, including the only Black doula collaborative in Rochester, New York, as well as referrals and outreach. Healthy Baby Network also has several signature events to support better understanding and interventions in the community, and to lift the voices of Black and Brown mothers, families, and communities. So Healthy Baby Network secured the PCORI Engagement Award funding for the 16-month project in 2019. So these funds were secured to help communities increase their ability to participate across all phases of patient-centered outcomes research. Excuse me. So the PCORI goals was to build a consortium comprising multiple stakeholders, sectors in Monroe County. So the goal was to equip members to be effective contributors to PCOR, investigate local trends and factors contributing to maternal mortality and severe maternal morbidity, and explore interventions that might be tested and create a 5-year prioritized agenda. So the project objectives include to create and support a diverse consortium, identify local factors contributing to disparity in maternal mortality and severe maternal morbidity, achieve a consensus on what works now, what is ideal, and what is needed to achieve the ideal, and determine what research projects to pursue, set priorities for 5 years, and ensure the consortium's sustainability. So the approach that we took for this work is a community-based participatory research approach. And our work focused on building respectful interaction between our diverse group of collaborators. And time was spent learning about each other, our diverse perspectives, and how we can best collaborate to work on our goal. So how was the consortium built? So our work included multiple stakeholders, including Black mothers and fathers, community organizations, clinicians, and researchers. And we met monthly for about 18 months to work on the project. And so my piece in this work is that I participated as a facilitator and as a mother at the table. and to be included in this work felt great because I was able to assist in doing research with people who look like me and that share some of the same experiences as me. Also to know that my experiences uh, were used to drive some of the research that is being done. So as a participant, I was able to sit around the table and also share some of the experiences that I had as a mother and what were some of the things I went through during my pregnancy and during my labor. Excuse me. Okay, so the specific purpose of the listening sessions was to actively listen to the lived experiences of Black women in the Rochester community. So I really wanted to highlight the piece about actively listening because I feel like that's very important in the work that we were doing with the moms, and with the moms, and also the work that was done with the fathers during the listening session piece. So when it comes to active listening, I like to think about building connections and building trust and making sure that you are paying attention, the eye contact piece, the safety and security, and making sure to not miss any of the critical information that is being shared. And so that is something that was very important during the listening sessions that we were doing with the participants. Also, to acquire a better understanding of maternal issues from the perspective of Black women in the Rochester community in order to inform research, to learn about the lived experiences of Black mothers in the community, to utilize our active listening skills again, to ensure accurate collection of information, and to establish a welcoming environment that allows for uninhibited discussions. I do feel like in this space, we did a great job of creating a safe and secure space for our mothers. And I think it really helped that the listeners and the facilitators and the scribes were also Black women. And so I felt like our participants felt really comfortable sitting in at a table with us, having conversations about their experiences with someone who looked like them. And I felt like that created a safe and secure space for them. So the listening session facilitator training, I really enjoyed my time at this training. I felt like it was very, very informative. It was exciting to be invited to be a part of the work. And it allowed me to understand more about some of the issues around maternal mortality. And it also prepared me to be a support to the women that I would be speaking with during our listening sessions. So our listening session facilitator training included women, Black women who had given birth within the last 5 years. And the listening session facilitators were trained as part of, were trained to be a trainer, but then we also took part in the very first listening session as participants. So our stories were able to be included in the data that was received and to help drive the research that will be being done. And again, the listening sessions intentionally had only Black women as scribes and facilitators. So again, I feel like that really created a safe space for our women. And even after our questions were done and answered and we completed everything, we all still kind of hung around having conversations, and that just showed how comfortable the moms felt with the scribes and the facilitators that were at the table. So these are the 3 questions that we asked the participants. So what would you like to share with us today regarding your experiences during your pregnancy and delivery? What aspects of your interactions or experiences during your pregnancy went well? And what advice would you give medical staff to help them better address the various issues you may have faced? So these questions were very open-ended. So they were able to just share what they felt like sharing, what they were comfortable with. And as a facilitator, we were there to engage in the active listening, and we were able to kind of probe to get more information and the people were asked to share to their comfort level, so they were not forced to share anything they didn't want to share. But most of our participants were very open. They were very excited to be there, and they were excited to share their story. And it was a great experience for me. And it was nice to see how many different directions these questions led us in. So each person answered it differently, and it all just kind of went in different directions, but we were able to gather quite a bit of information. And I do believe that, like I said, having all Black women in the room really opened up the dialogue for our participants to share more and to share openly and to go a little bit deeper. And it just really felt like a great space to be in. And the other thing I did want to share is that with our listening sessions, we did offer childcare, transportation, food, and a small stipend for the program. So that was a really big piece, because with mothers, you can assume that they're going to have their children with them. So to create a space where they are able to just relax and be able to engage in conversation was very important. So childcare was big, and then helping them with transportation. So if we think about the different barriers that moms can face when it comes to just getting to different things throughout the city or just wanting to participate in different programs, having resources to help break down those barriers. And then food was important. I think it felt like kind of like a dinner, like a family dinner. It was very laid back, very just very relaxed. So the other important piece is that we did a listening session with the dads, which served as both a great opportunity to hear the voices and to echo some of what we learned from the moms. And also listening to the experiences of the dads can, the experiences of the fathers can impact the experiences of the mother. So if we think about a dad that's not feeling supported or just not feeling like their voice is being heard during the pregnancy or the labor stage, imagine how they may not be able to fully show up for the mom because of what they're going through. So I felt like it was important to hear what their dad's experiences were as well. And just to understand all the parts that can play, or all the pieces that play a part in the experiences of the mothers and how they can be impacted, also by the experiences of the dads. Overall, I feel like being at the table and being included in the consortium was very important, because as a Black mom and as someone who has given birth within the last 5 years, and being able to share my story, it just highlighted the importance of having not only content experts at the table, but also having context experts at the table to get a different view, to get a different input, and to really hear from the population which is being researched, and to really get an understanding. And it feels good to just be a part of research that is being done on a woman that look like me and women that share some of the same experiences as myself. And so I will turn it over to Twylla.
Thank you, Danielle. All right, you probably saw my mouth moving. I was telling my kids to stay in the hallway. All right, our results. This graphic shows the process for our work. This and other beautiful charts presented in this section of our work were produced by Dr. Amina Alio, who unfortunately was unable to join us today. From December 2019 to January 2020, we worked on recruitment of listening session facilitators and training of those facilitators. We conducted 5 listening sessions between January and February 2020 in local community centers across the city. From March 2020 to April 2020, the consortium reviewed the data and analysis and developed research questions. Most of that was done remotely for reasons we're all aware of. We used lots of Zoom calls. The qualitative analysis process was conducted by researcher members of the consortium and identified themes from the listening sessions. The preliminary themes were then presented to the consortium. As Danielle mentioned, we added a listening session for fathers, which provided additional validation. The analysis was revised based on feedback from the consortium and then validated by consortium members and mothers through survey and focus groups. The factors were then ranked for future research. Our project engaged 44 Black mothers over 5 listening sessions. Mothers' ages ranged from 18 to 43 with a mean age of 30. There was an average of 2 children per mom and an average of 2.7 pregnancies. The education of the mothers were diverse, with many having at least some college. The mothers were from 19 zip codes in the Rochester area, and these zip codes had varying incomes. Now, more about what we learned from the moms. Mothers' positive experiences included, at the mother's level, feeling prepared, informed about processes and what to expect. At the interpersonal level, having the infant's father's support and engagement, as well as having social support from community organizations. And at the clinical staff level, supportive midwives, physicians, and lactation consultants, as well as feeling involved in the decision-making about birth and delivery. Mothers' negative experiences included at the mother's level, having little knowledge of the process and expectations, and the presence of pre-existing emotional and mental health conditions that had not yet been addressed. At the interpersonal level, there was a lack of support and engagement from fathers, as well as lack of social connection to peers. At the clinical staff level, mothers said that they felt discriminated against due to skin color, country of origin, insurance type, and religion. Mothers also said they had the providers had little knowledge of the communities they came from, and they didn't feel that providers were listening to them. Mothers weren't feeling like they were included in decision-making processes. At the healthcare system level, mothers stated that they had no continuous relationship with the clinical staff and that there were no providers of color. At the institutional level, mothers stated that they had unsupportive work policies and a lot of financial burden. The summary of information is helpful. However, our interactions in rooms filled with Black mothers were powerful. And these quotes really bring to life what we learned and some of what our experiences were. One mom shared, "I wanted a natural birth. I was given an epidural without information or by consent." I'm going to pause here because it's important to point out that our consortium was made up of Black moms who acted as facilitators and Black moms who were there in other capacities. The group also had clinicians and researchers, and we went over so much detail, including these points and many others. A lot of times people said, "I don't believe that happened," but what we learned from moms really forced people to think differently and forced us to engage in some really difficult conversations. So as much as I feel this gives it life, I wish you could have all been a fly on the wall during those consortium meetings. And I think my colleagues would agree that we learned a lot about each other in this process. Another mom reported, "I was moved to the room in the back, away from all the other mothers, probably because I'm Muslim." And stop here. We had a listening session that was with moms who were refugees, and a lot of those moms were Muslim and wore traditional garb. And it was really hard to hear this, but so important that we had these dialogues. Another mom stated, "I wanted a water birth. I had my birthing plan, but he ignored it. I gave birth in the hospital. I felt like they were pushing me to have a C-section because I think they get more money for it." I think someone's line is unmuted, sorry. "They kept talking about abortion, even though I kept telling them I didn't want one. I finally switched to a Black provider who understood me and worked with me to start treating my son in utero. That mom was a really interesting mom. Her son had a congenital disorder, and she refused to abort him. She kept hearing the same thing over and over from providers, and she switched to a doctor that supported her decision. She's since moved on to advocate for the condition that her son has across the country. She's really active supporting the other mothers like herself who choose to have their children despite this condition. This graphic shows how the supportive factors or positive experiences and the maternal stressors or negative experiences line up across broader categories. Both supports and stressors were present at the mother's level, interpersonal level, and the clinical staff level. However, only stressors were present in our data for the healthcare system and institutional levels. All levels aggregated to areas affecting the pregnancy experience as shown in this graphic. Mother's level impacted, mother-provider communication and emotional and mental health. The interpersonal level impacted social support and emotional and mental health. The clinical staff level impacted mother-provider communication and emotional and mental health. The healthcare system level impacted mother-provider communication and emotional and mental health. And the institutional level impacted emotional and mental health. Emotional and mental health and social support interacted with each other, or impacted each other rather, bidirectionally. The mothers who attended sessions and the consortium provided feedback on the factors to rank them in order of importance for the next steps in this work. Number 1 is mother-provider communication. Number 2 is emotional and mental health. And number 3 is social support. So for conclusions and next steps, based on our listening sessions with Black moms in Rochester, mother-provider communication is an important factor affecting Black mothers' experiences with perinatal care, healthcare. Mother-provider communication is affected by maternal health literacy, provider-clinician racial bias and cultural bias, as well as discriminatory actions. Mother's mental health and emotional well-being is affected by or exacerbated by these experiences. The consortium is moving forward with plans for research on and implementation of interventions to improve mother-provider cross-cultural communication and relationship building. Finally, none of this work would have been possible without the PCORI grant secured by Healthy Baby Network. Working with their executive director, Sharita Bullock, and others in this organization have helped to bring this work to fruition, and it has been amazing. The Black mothers and fathers who participated in the listening sessions have been so gracious with their time and stories, and for that, we will be forever grateful. And finally, the consortium full of incredible and talented mothers who wear many hats professionally and in the community. Clinicians, researchers, maternal child health experts, and doulas were a joy to work with, and I'm glad to still be a volunteer with the consortium in my new role as executive director at Health Connect One. And with that, we will open up for questions, and the colleagues over at UIC and Kay will help to facilitate those questions. Thank you.
That was an awesome presentation. We do actually have some questions that Karen has put over in the Q&A. Give me one quick second, and we'll kind of facilitate those out. One of the questions we have from Deetra is, did the context experts contribute to the 5-year research agenda?
So I will pipe in, others from my team, if you feel free to add. So the 5-year research agenda, all of the information that was used to start building out that research agenda was from the listening sessions. And it hasn't been built out in its entirety. The consortium is still convening, and the points that you saw in there, those different areas or themes, if you will, those were all validated with folks that have been to the listening sessions, so our context experts who attended via surveys as well as focus groups. As we continue moving forward, we will proceed and engage with those groups again. The challenge, I think, which is often a challenge for research, is funding. We actually just submitted a new grant for additional funding to put some of this work into place, and we've been pretty resourceful in finding other opportunities to keep moving forward with this work. But the short answer is absolutely. Our work is centered and built with community. Nothing we do is without community. Was that good, guys? All right.
That's exactly what I would say.
Our next question reads, is there any skew to the age of the sample? I'm not really sure in what part of the presentation that's actually in reference to.
And we can go ahead and unmute Willie Elliott, who joins us from PCORI, or from Peoria. Sounds like PCORI. Let me make sure that I can try and unmute so he can ask more to his question. I think this was in response to the listening sessions. Are you with us, Willie Elliott? Are you able to ask your question?
Yes, I'm right here.
Okay.
Hi, I just wanted to know if for the sample, it mentions that the range of the sample is from 18 to 43 with an average age of 30. I just wanted to know if most of the participants lean to be older in this range or lean to be younger.
That's a great question. I don't have the answer off the top of my head. I'm happy to share more detail offline. Remembering what was going on in the room, I think that mean age, the bulk of people kind of clustered around that. We didn't have a lot of people who were younger or older in the sample, but I can dig in because I do have all the data.
What I would say though is that the average age of first pregnancy in the US is a little younger than that, so that we probably skewed a little bit older. And remember, it's a pretty small sample size.
Yeah.
But also we're a little bit skewed toward more educated. And just probably some of you are aware that, you know, what the data show is that college educated Black women tend to have like sort of the worst risk for severe maternal morbidity, so that education seems to almost be not protective, but the opposite for unfavorable birth outcomes. So, and we don't know why that is, but it's certainly not a good thing.
Oh, okay. Thank you.
So we have questions just about sharing your slides. I know it's a small question just to ask of your team. Are slides going to be available after the talk?
I can definitely double check. There were a couple people who've contributed. I'll check with them. I can't see why not. I mean, the presentation's available. There's all kinds of things you can do with technology. So the answer will likely be yes.
To our speakers, if you haven't had a chance to check the chat box, there was a lot of action going on as all three of you presented your presentations. A lot of personal connections to the work with personal experiences that patients have had, current situations that individuals are experiencing, giving shout outs to the fathers and the husbands, adverse birth experiences or birth trauma experiences in hospitals. So I'm not sure if you're able to speak to any of the responses in the chat box as people were experiencing your presentation.
This is great. If I was looking in this, I would have gotten so distracted. It's awesome. There's some wonderful comments. Thank you for sharing, everyone. One around, I wish someone would have listened to me 6 years ago. There was one participant that has stuck with me in a way I can't explain. But she shared with us that she experienced depression before she had her first child, and her first child was 16, and she had just had her last child. And yeah, it was a huge range of time to experience this depression without treatment or support. So clearly support is necessary. I think Danielle shared that during the listening session, facilitator training, that there was a lot of lingering afterwards. That literally happened at every single listening session. Rec centers were closing and no one wanted to leave. So that really lifted to us the need for these sorts of interactions and this kind of engagement. I'm glad that Danielle's doing her podcast. I'm sure she's gotten some folks who tuned in to talk, especially right now while we're all kind of socially distanced. But there was definitely a need to be heard.
Yeah, I think the support piece is very important. It's just important for moms to just feel like they have someone out there that can, support them and just be a listening ear, especially when it comes to the mental and emotional piece. Being pregnant can sometimes isolate you from your friends if they're not pregnant or if they don't understand what motherhood is about. And that can leave moms feeling, lonely, which then can easily start just a ripple effect of other things just starting to happen when depression and anxiety sets in. So the support piece, I will say, is very important. And that is the biggest reason for my podcast, to be a support to moms and to have a space where they can go and just hear from other mothers and learn more about how they are making it through motherhood and different strategies that are working for them.
What I might add is, as I look at the chat, I think a lot of you are reiterating some of the kinds of things that we were told, by women in Rochester, and it just reinforces very much our desire to further this work as we hear, we know this is not unique to Western New York at all, with the kinds of experiences that women related to us. We're very interested in looking at implicit bias training, but going beyond that, because the data show that implicit bias training doesn't really mitigate racism. And so we need to do more. And is that anti-racism training? Is it something else? But we really see this mother-clinician communication as so profoundly important. And this research just, shows that. And I think, some research journals will look at this and say, well, this is qualitative research. That's not good enough. But qualitative research is what it takes to get this kind of data and this input and to really hear from those who go through childbirth. So we really want to elevate this because these are voices that need to be heard. But now our next step is, how do we, other than training Black clinicians, which is really key, but how do we get clinicians of all races to listen to their patients?
Yeah.
Guys, the questions are coming in so fast. There are so many. I want to honor the clock. There are questions about provider training, if you were able to give this presentation to providers. So I know Dr. Hartman, you just mentioned that. So if one of you could share, have you been able to give this presentation to other groups? And then second to that, another question relates to the type of providers. So it says, were you able to identify a type of provider, such as FQHCs, federally qualified health centers, that can sometimes provide more wraparound prenatal care than private practitioners? And the question goes on to include the role of doulas and navigators and communication.
Scott, do you want to talk about sorry, Karen. Scott, do you want to talk about the most recent presentation you gave?
Yeah, so we were able to, the one other clinician in our clinician who's like a physician midwife type person in our consortium is within the OBGYN department, and we were able to do a grand rounds with a lot of midwives and physicians listening. But we continue to hope that as we progress with this work, to really include physicians and midwives and nurse practitioners and who are dealing with women of reproductive age, not necessarily pregnant or peripartum. So, and I would say that the positive feedback that we heard from women was about doulas, midwives, and lactation consultants, more so than physicians. So that was very important for me to hear that, and for the physicians in the room to hear that.
Oh, the facilitator training, that was another question. We had the question about wraparound care was another question. That's definitely something that Healthy Baby Network is really keenly aware of and interested in. They have a program that is situated within Healthy Baby Network now. It used to be within the U of R that does a lot of perinatal community health work. This is something where we're making sure we have care teams and people are working collaboratively. How that's functioning right now is in motion. But things we've learned from this work will definitely be folded into that, making sure that there's enough communication bidirectionally between people who are in the community, working with folks, and people who are in clinical settings. We know so much happens in community, and there's a lot of intervention that can be done there. So that's one, stay tuned, there'll be more on that. In addition, the facilitator training, I think there's a couple questions about that. The facilitator training and the training that we experienced as a full consortium was pretty intensive. I think I went past that slide a little too fast, but that work involved all of us talking about our own biases and microaggressions. So for the entire consortium, which was really diverse, there was a lot of work that we had to do personally and interpersonally to be able to work effectively together, and that can't be understated. So I'm sorry I flew past that slide. That was really important work. Coming to the table ready and having the table ready, right? All of that was really important. We spent a lot of time on that. The facilitator training was really to get people to do that active listening. We were fortunate that the facilitators and scribes who came to us, some had some incredible skills. Danielle, I'm gonna lift you up real quick. Danielle is a counselor. She's worked as a crisis counselor in the police department. She works as a mental health counselor. She's incredible. So the ability to be able to actively listen is something that she's already been trained in. We also had a doula who is one of my favorite people ever, who is a wonderful listener as well. So we had some folks who had some of those gifts and those requisite skills already, but not everyone came with that. Folks were really well connected to their community, and that was an important component of bringing people in to do that facilitation, because A, they could help recruit. B, people who are connected to community a lot of times have those skills naturally to listen and to know who needs help and who to point in different directions. So really it was about actively listening. It was going through that actual listening session process so that it was like, it wasn't hard when you had to go do it because you'd experienced it, right? That experiential learning, I've been through the listening session, now it won't be so difficult to facilitate that. We have more information, and if you'd like, I can definitely share more offline. So.
Yes, there are several questions about listening questions in both the chat box and in the Q&A session. So I'm not sure if Dr. Dillion or Danielle, you can speak to those. People wanted to know about resources for the training, if it's available, if you could point them in that direction. And there's a question in the Q&A box about what's next. What types of interventions are you proposing after your listening sessions? And how might health navigation facilitate the findings?
I don't want to keep going, I'll go. Scott, correct me, Danielle, correct me. So next steps, we just submitted an additional grant to PCORI to actually implement some of our work. And that work at this current juncture is really going to be at that mother-provider communication level on both sides, engaging with providers to make sure that, you know, it's interesting, an article came out about the Hippocratic Oath and the role that providers have in really making sure that everybody's doing what they're supposed to do. And that was really great to see. It came out, I think, yesterday. It's on my LinkedIn. But that article really is speaking to some of what we're doing, including equity in that Hippocratic Oath and making sure we're monitoring each other as providers, if that's our role, and making sure that, you know, moms, as they're entering clinical settings, are comfortable and have what they need. This work can be done in community, right? There's several different modalities to get this done, but we're still developing that out. It's really, the implementation will have a lot to do with funding, which is an unfortunate situation, but we're definitely seeking additional sources of funding, and we're keeping the consortium together to continue that exploration and to continue conversation and keep people together, because that's really, really important in this work. We have some local funding that will help support that, but to do a full-fledged implementation of this first intervention around mother-provider communication will definitely require additional sources of funding. Scott, did I leave something out? I'm sure I did. That was a multi-layered question.
Yeah, you didn't leave anything out, but what I would say is that so University of Rochester is under task to develop an anti-racism agenda because of a lot of local incidents. And so, you know, we're fortunate to have, prior to some of that, have formed this consortium that includes University of Rochester, but University of Rochester is not the driver, it's the community. And so but the medical center partnering in this and knowing that they have actually written out an anti-racism agenda. And so I think, and I hope that we're joining this at the right time, that we can really leverage some resources, because we know that the clinicians will have to go through some kind of training, and it's just what that's going to look like. So we have a lot of ideas, and we're working on like really building them out to make them meaningful, to sort of go beyond implicit bias alone.
I think that's a great lead into the 2 remaining questions in the Q&A box, because you're talking about more of the system, changing the system and policy approaches to making sure that we're addressing health needs. And in our poll of who's in the room, we saw we have representation from researchers, clinicians, providers, patients, even policymakers are with us today. But we don't have payers in the room. So one question speaks to Medicaid payers and risk assessment during the prenatal period. What is your sense about the role of payers in solving these problems?
That's a really good question. I don't know if Scott wants to go first. I deal with them in the sense that I'm really well versed in working with Medicaid, having worked in Medicaid reform, but I'm not actively billing Medicaid. So I may not have the most up-to-date information in that area. I would say that the role of communication isn't something that is often really lifted, particularly what's happening to make sure that mothers are comfortable engaging and having dialogue with providers. These are things that are very different than what we've looked at before. There's been a heavier emphasis on social determinants of health and other layers than what have existed prior. I think this window of opportunity that exists before us, where everyone's paying attention to racial equity, could spur some new opportunities as far as payers are concerned. But I mean, really pointing to the fact that if we are able to put one of these sorts of interventions in place and keep track of what's going on, lifting that to payers, so they can see the actual evidence around effectiveness and really have an ongoing understanding of some of this work that we're doing. I don't know, Scott, do you have anything else? Danielle, anything else? It may not be as thorough an answer as we wanted, but advocacy is key. Yeah.
If Danielle has a thought about that.
Yeah.
I'm not as well versed with Medicaid either, so I don't really know how to answer that.
I do see something in the chat around bundled payments. I spoke a bit about the team approach to supporting moms and babies. I think that's really critical. I think one of the challenges that we see right now, and one that's at front of mind for me working at Health Connect One, is that community health workers aren't generally reimbursed for by Medicaid. And the work that's done in community with mothers is a crucial component of ensuring that mom and baby are safe and healthy. Community health workers that know the community health workers that are of the community, a lot of times that work is not as elevated as it should be. And I think that's one important component. And that's some of the workers who are at Healthy Baby Network as well, who's one of Health Connect One's partners. This work really needs to be in the community, of the community, similar to the work that we've done here.
That's pretty much exactly what I was going to say, that I think payers are way behind on, first of all, just equity, right? We need a national health plan, and I'm not going to preach single payer, but we need something that's equitable healthcare that covers all Americans, right? So that's not going to fix racism, but it is an important part of leveling the playing field. We need national healthcare. And then number two, we need insurers to really look at what works and really what saves lives. And so insurers, the payers, need to have an anti-racism agenda of their own, but they also need to support things that work, like lactation and doula services. And navigators can be in the form of community health workers, or I mean, doulas often have a navigator type role, but those are the things that are going to change, that are going to improve care. And so just paying for a traditional medical model doesn't work. And so the payers need to get on board with that.
I agree.
Yeah.
We have one very last question. I'm being mindful of time. I know we're a few minutes over. And I encourage everyone to stay with us for the after party. Several of our patients and partners from our advisory boards are here to talk about what perinatal research is during the context of COVID, and maybe strategies for you to get involved. Our last question is from Dr. Mary Kimmel. It's very similar to your responses. She says, how can we advocate for greater time for listening care in larger teams with institutional leadership, with health insurance, and with government? So maybe it's the advocating for greater time for listening care.
That is a great question. I think so. Being able to actually spend the time that's necessary as a clinician with a provider, with a patient rather, it is really important. I think that it's going to take a little bit of time, and this is why I mentioned community health workers. It's going to take a little bit of time to catch up and to be able to do that in the current billing model, because the current billing model doesn't allow for that time, right? We don't have a model that does that. And I think that the value of other health supports that exist in community and in other settings, so mainly in community-based organizations, those other supports that exist, peer supports that exist, those are really heavily underutilized and definitely underfunded. So when it's not possible to do that, I'm not saying we don't advocate for it. By all means, we need to advocate for it. But in the interim, we don't want to lose anybody else. So making sure that there are other opportunities for people to support those communities and families in community for now is a good stopgap while we advocate for better listening time, greater ability to listen, more people advocating for patients with other providers, right? There are a lot of ways and layers to do this work. Clinicians advocating for more time because they know that that matters, knowing who's in front of them, knowing something about them, knowing about that person's community. That being lifted, that wasn't lifted once in what we learned from moms, knowing about the community, shadowing a community health worker as a clinician, know what's going on in the community. One of my students told me that. I was like, that's a good idea. So doing that kind of work to really be embedded, I think is important and will lead to greater advocacy for more time. I don't know, Scott, what do you think? Danielle? Anything?
I mean, I would say that I agree with everything that you said, and I think that it definitely can start more quickly at a community level, and empowering our moms to feel comfortable enough to ask questions, and kind of educating them on strategies to use for their questions. So I know with my doula clients, I encourage them to write any question that comes to mind, write it down, have a little journal. So when you do go to the office, you don't miss out on any of those questions that you did have. So I really help them to find their voice and help them to feel comfortable enough to speak up and ask questions when they are in the offices with the doctors. I think that's where it can start more quickly, like you said, as we continue to advocate and do work for a higher level of change.
Wonderful. There are applauds coming into the chat box. I just want to thank you on behalf of Perinatal Connect, all of our partners here in Illinois and in Iowa. We thank you so much for spending the afternoon with us and sharing just insight into your project. I think we've all gained so much from what you've shared this afternoon. There will be an evaluation form that goes out after this. Please help us by filling out that form so we can learn how to improve in the future and what was most useful from this webinar series. If you have a few more minutes in your day, stay on with us. We have over 20 patient and provider partners that are here to answer your questions and engage with what you're thinking right now about patient-centered outcomes research, community engaged research, and how do we get more perspectives in the research problems to solve these problems and find solutions that are shared and important to all of us. We want to thank our funder, Patient-Centered Research Outcomes Institute, for all of their support for this work, and stay on with us. So now I'm going to ask our panelists to please turn on your cameras and join us now. Let's see.
It is. Okay.
Hello, we see you. Thank you.
Oh, come on, I can scoot over. Can they see us?
Yes.
Hi.
Hi.
That was amazing.
It was awesome.
We were sitting here just agreeing with everything.
Yeah, it's what we see. It really spoke to the heart of the work that we do here. Amazing.
So I'm curious for our partners, what motivates you? Why do you stay in the work? Your perspective might be as a patient, as a provider, as a student or researcher, but what motivates you? Ruby and Sheila, would you like to go first since the camera's on you?
Yeah, I'll go first. What motivates me is knowing that I'm making a difference, and not just the mom and baby, but also the dad and the siblings also. And also knowing that when I go home at nighttime, that I've done all I could do to help the person or the family, and that my goal is to continue to try to help do more research, to help find out all I can about how to get more involved into the community and focus on better health care for the community and families.
Yeah, and we're both moms.
Yeah, we're both
so
moms.
We've been on that side of it as well. Ruby's a mom of color.
Yeah.
So I mean, we relate to our clients on a personal level. We know some of their struggles personally, but both of us have been in this for a long time, and we've seen a lot of suffering based on women's lack of access.
Yep.
And
also having insurance, the difference of not having insurance and having insurance is also, we both know on both ends of that, so we understand that, and that is also important for us. And so we advocate for parents to apply, especially women who don't have insurance, for the medical card or some kind of help, or we got free clinics you can also attend to. So,
but we're just like sticking our finger in the dam, so to speak, in the hole in the dike. To see a project like this, it's actually addressing some of the roots of the problems, getting to the bottom of what's happening here and how do we fix it. That's just really exciting for us.
Yeah.
Wonderful. Maybe some of our newer board members. I've seen Jade O'Connell from Iowa, recent addition to the board. What interested you in a research board and sharing your opinion with researchers? What motivated you to apply?
So I had a very serious birth tear, a 4th degree tear. So I tore up my rectovaginal wall, and they didn't quite catch it in the hospital. I actually told the nurse that I felt like I was passing gas out of my vagina, and she just told me she's never had anyone complain about that and sent me on my way. So I don't want, I'm sorry, I don't want a mom to ever feel that way. Period. Like, she's not to be trusted about her own body. And ultimately, like, it just hurts my heart to see that these moms were treated that way. Like the mom who was being pressured to have an abortion and she just wanted to care for her child. Like, that's not okay. And it shouldn't be that way, and moms should have a say in their care, and they should be trusted and listened to. And I'm sorry, I didn't mean to get emotional, but it's just unacceptable in my opinion. And I really want to change that, especially in rural healthcare around here. Like, we don't really have quality care, and that's my why.
It's so moving, Jade, to hear your experience. And it was an unfortunate experience for you that clearly has been traumatic, and you're using that to help others. And that's so altruistic and so noble. I can say, as a researcher who also wears the patient hat, but long-term researcher before that, I am just so immensely grateful for your perspective. And having your voice is going to make research that much better, right? To have findings that are relevant and matter and actually help find solutions for people. So we're so happy you're here, Jade. Yeah.
Yeah. What?
Yeah, I think that that's one binds a lot of us together, is that we're women and we've experienced some, aspect of this. And as you said, Karen, we take our own pain or trauma or issues and, we try to do something with them, to make things better for someone else.
Mhm. Yep.
Thank you, Jade. What about others from the Illinois team? Some of you have been on the board for anywhere from 8 months to 2 years. So what are your driving motivations for participating in a research advisory board? And maybe what do you find beneficial to share with others?
Well, our drive force is fine.
Megan or Emily or Rachel? I see you smiling.
I'll go, Karen. Well, I joined the board primarily because I wanted to use my experience with postpartum anxiety, postpartum depression, to help other people, similar to you, Jade, knowing that the difficulties you've been through, not wanting other people to go through similar difficulties. I moved to Champaign, Illinois, just about 8 weeks before my daughter was born. And so I went home from the hospital, not knowing anyone in town, not having a primary care physician, not having a therapist, not having a friend, I had my husband and that was about it. And so when my anxiety skyrocketed just a few days after she was born, luckily I called the midwives who had been treating me prior to that, and they helped advocate for me to get into counseling. And I only knew to do that because I'd had an experience with anxiety and depression before when I was in the Peace Corps. And then it kind of became like the reason I've stayed on the board for 2 years is because I was a stay-at-home mom, and this was like a chance to share my voice and do something intellectual and talk to people about studies and research. And I don't know, it's just been really interesting. It's a really different way of getting to share what it's like to be a mom.
Thank you for that, Megan. Maybe one more share from another board member?
I can go,
Rachel?
Karen.
Okay.
Yeah. So I mostly, over all my pregnancies had a pretty easy experience. Maybe a little postpartum, baby blues, depression, anxiety kind of in there, but it didn't feel like a big part of my story. But I am a doula. And so I think the big thing for me is just learning about other people's experiences and how, finding those holes where their care quite wasn't what they were hoping for, and how can I, plug them in with different resources and connect them with different people, and even provide, some of that same support that they were looking for that they didn't get, myself, just kind of being that listening ear, or like I said, just being able to give them another idea of somebody else to talk to, or some questions to ask their care provider. So I have really just enjoyed hearing about all the different experiences that other people have had through pregnancy, dads, moms, the whole bit. And so I've enjoyed learning about all of that, and it's really helped me understand the full picture of what a lot of people go through during this time.
Thank you to our board members. This is just so valuable to hear the patient experience. And I think, as you mentioned, Jade, a lot of this is mapping on to the listening visits. It's the point of being heard and being involved in a larger system, being vulnerable, right, for the health of yourself and your infant. And how do you speak out and advocate for others? I'd like to check in with the rest of the participants today. We still have over 50 people on the line. And I'd like to hear from you all. what is your interest in joining today? Or maybe what are some questions that you have for our patients and providers who are on the call? I know some of you might have an interest in patient-centered research in terms of getting involved or leading your own projects. There are many comments in support of Jade in the chat box. Just hugs, saying your advocacy makes a difference. We've got hands up. Let's see here. Okay, so Linos, Muvu, and you're joining us for Zimbabwe. Your microphone is now on. Linos? Linos, we'll come back to you. Your microphone is on. If you unmute, you're able to talk. And Jeanette, we have your hand raised as well.
Can I talk?
Hi, yes, we can hear you.
You can hear
Okay,
me?
it's fine. No, thank you so much. I am so interested in the research. In some of my presentation, I always say, the family approach or the family policies, that addresses maternal, mental health, prenatal, and mental health issues. It's not, well advocated for. So I really want to thank the team, for research on the family approach, especially like men, in issues of maternal mental health issues. And I'm so much passionate about this area of maternal mental health. Like, Jade, I was so touched when she, gave a lived experience on this area. So I wish to thank you so much, team, for the wonderful work that we are doing, and looking forward, for more collaboration if opportunities arise. I really want to thank you so much for having me today.
Okay.
Thank you for that comment. Just the family approach too. We did that in the previous session about the importance of maternal mental health, but also paternal mental health. And we have related questions in the chat box about mental health for birth mothers who choose adoption. So what is their follow-up care and support? And that's a good question, a good priority area. Can we switch to Jeanette just for sake of time? Your hand is raised and your microphone is on when you're ready.
Oh, hi, everybody. Yeah, I was really just wanting to share a couple of quick things. I'm from New Jersey, and I listened to the last seminar and this one, and I have been, fortunate enough to have had PCORI engagement awards, and so I was impressed with your approach to engaging patients and the community more broadly in this relatively new area for PCORI, which is in the maternal and child health area. They've prioritized that in this next 10-year phase for PCORI. And I've been working in maternal mental health. Actually, that's really my specialization. So I'm just so impressed with the way that you, and I'm looking at you, Karen, because I see you as kind of the leader of this thing, of how you're doing this and how engaged your patients are. And so I was really glad I could stay extra today to observe all this. We have a PCORI engagement. Well, we have a PCORI comparative effectiveness research study, which is, one of these things that followed after our community engagement, our patient engagement planning grant. So I'm still actively involved, but I just wanted to say that I was wondering why I continue to be interested in this, but I see that, you seem so innovative in your with the way that you've organized this. So I just wanted to applaud all of you, but also I continue to learn new things just listening to the parents and the patients, and I'm very systems oriented in my approach now. So the translation between the patient experience and changing systems and practices so that these problems don't, burden the patients and cause problems down the line is really where I think the real secret sauce is, as it were. So anyway, that's enough. I just wanted to share that observation. And so policies and systems change are as important as, the patient provider communication. So that's it. So carry on, and I'm totally in your corner and wish you all very, very good luck in all of this work. So thank you for the chance to share a few thoughts.
Wow, much appreciated. Thank you so much for the encouragement. I think everyone is smiling and nodding and feeling validated that the work that we're doing is in the right place. It's really hard to change a system, and research is just one of those avenues. And if we're not conducting research that matters with findings and treatments that are actually supported by patients, so what? What's the point of all of it? I think today's session was super important to see who was in the room. We are lucky to have much support from different Senate offices at the US Senate. So there is some policy focus and interest in this work. However, we still need the insight of payers. Thankfully, we are building our patient-driven coalition and have some really dynamic patients in the helm that are driving this work forward, and patient advocates. So we just need to acknowledge again, Shades of Blue is on, Kay Matthews. I don't know if you have any encouraging words about both the grassroots and the grass tops work that you're doing to address maternal mental health, and the movement that we're all building, but the work that you're doing in Houston and nationally.
Of course, I think that this is setting the stage and the presence for others to follow the lead of, and always engaging with the patients. The patients are the key to a lot of the system changes that need to happen. So this is a great start. I definitely like what was just said about Karen, you being the leader and one to follow. I surely, I second that notion that we definitely should be all learning from these webinar series and encouraging that these continue, because these are important. It's very important to continue to incorporate the patient's voice. If someone would told me 10 years ago that this would be the work that I would be doing, I mean, I wouldn't say no, but I would just be like, I don't know how that whole thing is going to happen. And yet here I am learning how important it is that others' voices are heard, because I too have been, that my birth experience is not one that I hoped, prayed for, or anything, but it was that, right? And not being heard was the key contributor to everything that happened after that. And so listening to our patients, seeing the value that we bring. Again, we are the patients and we should be listened to. And all of the extra that can happen in a postpartum period can certainly be avoided in certain ways. So continuing to have conversations like this will continue to educate folks who may have just not looked at how valuable the patient's experience and their voice is to everything, or all the way across the board. We're talking research, policy, everything. Like the patient's voice is what's most important here. So I'm looking forward to the continuance of webinar series that continue to be just like this, giving those who would not typically have the platform the opportunity to speak and educate on a different level.
So before we end, I want to go back to Jeanette. Jeanette, are you still with us?
Yes, I am.
Okay. No, because I think your words were very encouraging. So I'm just going to squeeze a little bit and see if we can get just a little bit more. So our group has really built a dynamic force in our region of the Midwestern US. We have health fairs, coffee hours, town hall meetings, and we're moving forward, gaining a lot of momentum and interest. And then COVID happened, and we're still trying to engage virtually, but it's kind of strange. And we're still trying to keep that momentum going. We've been very successful with engagement awards. We've been invited twice for the broad funding announcements, but we haven't cracked that nut yet. And I know there are others on the call, like Venus Mahmoudi joined us last week, and I think she's a researcher in New York City that's interested in getting started with PCORI projects. So how did you stay positive and keep going from engagement awards, from the building, all the way to designing that broader comparative effectiveness research study that you are working on now?
Well, I actually have a short answer. The first thing is I don't take no for an answer. So I just didn't get discouraged. I submitted many, many LOIs before we actually, succeeded. The second, so don't take no for an answer, keep at it. The second thing is the key ingredient is collaboration. And in the business sector, they call these strategic alliances. So you may have to, begin to work with some other entities or individuals who are methodologically, excellent. So these scientific standards of PCORI are totally a sine qua non for success with the research area. So I would say those two things, really just persistence and just recognizing that you don't get it the first, second, third, fourth time, but just stay with it. The third thing though about this particular thing is to really, it's important to talk to others who have pursued this PCORI stuff because they know what the funder is really thinking about. And so, for example, they don't want to fund patient navigator kinds of things. And community health workers. So the kinds of things that you feel comfortable with, and it's like peer support with regard to maternal mental health. A lot of women really, really benefit from peer support, but PCORI won't, so you've got to balance what you're hearing with what is strategic. But there's something really important about PCORI. They're doing things now that have changing the face of community engaged activity, and they are a major source. So it's well worth putting in the work to figure it out because they are very, very serious about patient voices. So stay with it.
I think that's the perfect way to end. Stay with it. So I want to encourage you all to please come back one final session next week, Thursday at 4 p.m. Eastern. We're going to have Miriam Cooperman and Brittany Chambers, along with community partners, presenting, Fabiola Gonzalez and Dr. Bernice Curry, presenting on a large comparative effectiveness study that had to change once COVID-19 hit, and they'll explain their supplement for that. But it's based on community needs to address maternal mortality and maternal mental health among Black women in Northern California. So please join us next week. In the meantime, complete your evaluation surveys, and thank you again for spending the afternoon with us.